As Aditya kindly introduced, today's talk or lecture will be on a practical guide to acute inpatient psychiatry. The first thing that I'd request from you guys is to go onto your web browser and type in and kindly input menti.com. If you can see on the first slide, it says menti.com and it gives you a code. So once you search menti.com, it should ask you to input said code. And we're going to begin with a somewhat interactive session just to get an idea of what you guys, your perception on particular psychiatric topics. And then from there, we'll progress into the presentation once I've given you a bit of an introduction to some of these topics. So if you type in menti.com and indicate in the chat box that you've input the code, we'll begin with some questions where I kind of gauge what you guys' opinions are on particular subtopics. So once you've done that, please put it in the chat box and we'll begin from there. So, okay, I can see that we're getting some responses. So the first question is, what are the roles and responsibilities of a resident doctor in psychiatry? Some of you have said take a history, to do referrals, to clerk patients, um, to perform administrative roles, to prescribe medication, to perform a physical health assessment. And these are very correct answers, to be honest. Those are some of the roles and responsibilities of a junior doctor within an acute psychiatric ward. So typically, the main responsibilities for junior doctors within an acute ward would be medication prescribing. So we're responsible for prescribing psychotropic medication. These typically include antipsychotic medication, antidepressants, and by and large benzodiazepines and medications that are used for the rapid tranquilization of patients. Like someone kindly input as well, we are responsible for clerking patients as well onto the ward. Clerking will usually comprise of um, the patient's name, the key identifiers. We'll start off with their psychiatric history, whether they have significant medical history depending on age and circumstance. We then go on to the circumstances surrounding their admission to the ward. So this could be patients, let's use initials. SA is a 27-year-old female of, let's say, South Asian background, who was being treated in the community with aripiprazole, 10 milligrams. She has been non-compliant or non-congruent with her medication, which has resulted in her returning to the ward because she has deteriorated in her mood and mental state. You'll also take a social history. You conduct an interview as well. You'll gauge the patient's capacity. You will perform a risk assessment, and then you'll proceed to do the physical health examinations that are required for said patients, and then prescribe all the relevant medications. So within the NHS, we have an abbreviation called PRN, and PRN simply means medication that is prescribed as and when required. And so you prescribe the PRN medication, mainly medication that would help to kind of manage a patient's agitation. A lot of the patients that do come onto a psychiatric ward can be quite restless, irritable, physically and verbally abusive. And a lot of the time, this is the most scariest period of their life, especially if it's a first presentation to a psychiatric ward. Okay, so those are some of the elements that you'd expect a junior doctor in psychiatry to do. So some of you answered that routine physical health investigations would be required. Is anyone able to kind of give an idea of potential examples of physical health investigations that would be routine in an acute ward? And don't worry, there's no wrong answers here. Whatever you think, you just put this lecture is just meant to be informative, just to give you further insight into what to expect, because psychiatry is quite a niche specialty. Psychoanalysis, we've got ECGs and blood tests. CT scan, MRI, FBC is there as well. Toxicology, potentially that was a good one. Group and save. Okay, so there's various means through which patients actually enter an acute psychiatric ward. If they're coming through the ED pathway, which is the emergency department pathway, they would have had some blood tests and whatnot done, and they may have had toxicology done if, for example, they've been admitted with an overdose. A lot of psychiatric patients can be clinically depressed and experienced or psychotic and experience suicidal ideation to the degree that warrants that kind of compels them to overdose on either their psychotropic medication or medication that they've illegally obtained from like the black market or over the counter. So yeah, but in terms of routine physical health investigations, once a patient is on a psychiatric ward, we do broad blood screening. So we do FBCs, which is the full blood count. We do renal function tests. We do use and ease. We do thyroid function. We do HbA1c to determine if the patient is potentially diabetic. We also do tests for prolactin to see if they have raised prolactin, as this can affect libido. We also do a menstrual cycle as well, of course. We also could do some lithium bloods if the patient's been admitted on lithium bloods, on lithium and requires lithium monitoring. And we do a physical health assessment. I don't know whether you guys have heard of your doctor's A to E's. So when a patient comes onto the ward, we'll do an A to E assessment on them to assess their airway, their breathing, their circulation, disability, their GCS as well. And we do the exposure setting where we look for any kind of bruising, self-harming marks. We assess their calves, see if they're softened on tendon, rule out any deep vein thrombosis. And we also assess their mobility and functionality. Is the person able to attend to their personal care? Are they able to shower and mobilize independently? So that's kind of what a physical health assessment will comprise of. You'll have routine vital sign monitoring as well for patients, where you assess their oxygen saturations, their blood pressure as well, their respiratory rates, things of that nature. And this is routinely done on an acute ward on a daily basis. The physical health exam that you would do would be on admission, and if any kind of acute deterioration were to occur on the ward. I've given you the blood test. You would also perform a mental state exam on admission. A mental state examination is kind of to gauge whether there are any psychotic features or elements. And it's also to gauge the patient's mental state and mood. there are like a few domains that kind of would encompass a mental state exam, which we'll go through later. And one of the most important things actually would be the ECG, which someone's also mentioned as well. In ECG, we would do on admission because with the antipsychotic medications, a lot of the times it can cause something called QTC prolongation. And with QTC prolongation, the ventricles take longer than normal to kind of recharge between beats, and it's measured as an extended time between the Q wave and the T wave on an ECG, and it's kind of like an electrical disturbance that puts you at risk of arrhythmia, and with the arrhythmia, most notably an arrhythmia called torsades de pointes, it can lead to sudden cardiac death. So ECGs are very routinely done in psychiatry. So prior to starting a patient on any antipsychotic medication, especially if they're antipsychotic naive, you would have to do an ECG just to gauge what the QTC is first, and also to kind of rule out any cardiac pathology that has been known or unknown or potentially worsened before initiating them on antipsychotic medication. As far as the scans are concerned, i.e., CT scan and MRI, they're typically done more so in the old age, just to old age psychiatric wards, just to determine whether there's been any kind of involution or atrophy, and you kind of determine whether it's age related or whether it could be signs of Alzheimer's dementia or dementia of Lewy bodies as well. So, what do people think a mental state examination would comprise of? What are some of the key elements we'd look to assess as a psychiatrist when attempting to assess someone's mood and mental state? Appearance, yeah, absolutely. Someone's appearance can tell you a lot about their mental states. Imagine someone coming to your clinic or onto the ward. They're quite dishevelled, unkempt. They look like they haven't been attending to their personal care. Maybe they're malodorous. They look sleep deprived. They've got significant bags under their eyes. That can give you insight into someone's mental states. So we've got speech, sleep, mood, appearance, how they think, their perception, which is true, and questions about themselves as well. Yeah. Because mental state examinations are typically done during every kind of review, it's something that would be ongoing as far as questions surrounding themselves are concerned. You'd always ask, how are things on the ward? Um, Understanding their illness. Yeah. So the mental state examination does give you kind of insight into a patient's presentation um, in time and in real time, and that can kind of give you an insight into whether they're progressively improving on their current medication regime or whether they require titration of the medication. So the main domains from a mental state examination are a patient's appearance and behavior, their mood, and typically in psychiatry, we like to describe mood as euthymic if it's normal, and dysthymic if they're quite low. A patient, if they're quite high in the mood, can be described as elated. If the patient has a history of bipolar and they are full blown manic, you could do that as well. And we also like to see to gauge their effects. So mood and affect go hand in hand, and appearance and behavior go hand in hand. The reason behavior and appearance go hand in hand is because with the antipsychotic medications, at times it can cause side effects with the patients. Some of the side effects that you are quite notable during reviews are movement disorders. You usually have extrapyramidal side effects, which is kind of like medication-induced movement disorders caused by um, the dopamine receptor blocking kind of mechanism of action that the antipsychotic medications do. You also have dystonia, and you can have something called akathisia, which is like um, uh, it's like an observable restlessness where someone maybe is agitated, they can't sit still, they're repeatedly tapping their feet, and it's an involuntary movement, which is the most kind of important thing to note. So, how can we help support patients with um, remaining compliant with their medication? So, whilst you guys put your ideas there, I'll finish what is mental state examination consists of. So, after your mood and affect, you have speech. Sometimes when patients are kind of clinically depressed and low in mood, their speech is affected as well. They can become somewhat borderline catatonic, experience psychomotor retardation. Um, for speech, you would kind of look to assess the rate, the rhythm, the tonality, the quantity of speech, because sometimes someone suffers from mental illness, they can have alogia, so they will have like a poverty of speech. You can also have echolalia, which is kind of like uh, repetition of what you say to them, or palilalia, where they keep on repeating the same word over and over. You also look to assess their thoughts. So you assess the thought form and thought content, or what they're describing during the review. Psychotic, do they have delusions? For example, some patients that I've reviewed on the wards, they'll be like, I've been working for the Queen for the past 25 years. I'm also a cardiologist consultant, and on the weekend, I may kind of partake in some appendectomies or open heart surgery as well. So we look to assess the contents of their thoughts. And then we look at perception. So are there any perceptual abnormalities? Is the patient experiencing auditory or visual hallucinations? Are they hearing voices? Are they seeing things that others might be unable to see? Are they experiencing tactile hallucinations where they maybe see and feel spiders crawling over their skin, and which is manifested or represented with um, an itching or strong impulse to scratch themselves? So after you kind of gauge the perception as well, you then move on to the cognition portion. So you assess whether the patient's oriented in time, to place, and in person as well. And then you would look to do a risk assessment based on the patient's presentation at the time. So, how can we help support patients with remaining compliant with their medication? We've got routine building, past treatment history and other treatments, which is good. That's good. Frequent check-ins. That's a very good point. Prescribed depot. That's probably one of the gold standard things to do when someone struggles with compliance. Follow-ups. That's true. Memory clinic. Yeah, that would be very, very true as well. For example, if the patient is cognitively impaired and they're on an old age ward suffering from, as I mentioned before, some form of dementia, that would be very useful. Explaining the meaning of compliance, yes. Whenever by the kind of clinical way to explain the meaning, or to kind of assess whether patients understand what you're trying to convey to them in terms of the importance of the medication, would be a capacity assessment. Capacity is kind of a fluid thing, and you need to assess it based on specific decisions. Listening to their concerns, reassessing them. Psychoeducation, that's a gold standard as well. Familial support, that can be good. Clear communication, that's very true as well. We don't like to use medical jargon when communicating with patients' families, or patients themselves. So that's true. So as far the main things with supporting compliance are, to be honest, a lot of the things that you guys have actually mentioned today. Routine building is one, and as far as routine building is concerned, a lot of occupational therapists on the ward will support the patients with building a routine and engaging them on the wards. Prescribing depot is probably by and large the gold standard because depot medication is an injectable, long acting form of the antipsychotic medication that remains in the patient's system for, let's say, it varies from a week to a month before they need a subsequent dose. So that's a good one. CTO, I didn't see that one, but I've just seen it there. CTO is very true. When a patient is under a community mental health team, a CTO is kind of a community section order, whereby if they are uncompliant with their prescribed medication and they start to deteriorate, they are legally obligated to be brought back to the acute ward so that they can be restarted on their medication and reassessed as promptly as possible. Because with mental health conditions such as schizophrenia, bipolar affective disorder, and condition and depression, the more admissions you have, the more difficult it becomes to treat. So ensuring compliance is one of the best things you can do to make sure someone remains kind of mentally stable in the community. Psychoeducation as well is a good one because understanding what having an understanding of why you take the medication can help kind of reinforce the need for compliance. People won't kind of remain compliant if they don't understand the need or the dangers or the risk of being uncompliant. What are the key domains assessed in a mental capacity assessment? What do we think a capacity assessment comprises of? If we were to understand if a patient is able to, let's say, be capacitous in making a decision, like um, let's say, for example, the patients are diabetic and they don't want to take their anti-diabetic medication like they're prescribed insulin or metformin, and they're remaining in a state of hyperglycemia. Do they understand that they could potentially experience emergencies such as diabetic ketoacidosis? Do they know what the implications of diabetic ketoacidosis is? So, what are the key domains? Understanding, communication, and retaining decision making. Yes, all of the above. So, when assessing a patient's capacity surrounding a specific decisions, number one, do they understand what you're communicating? Are they able to retain what you're telling them? Are they able to repeat back to you what they've been informed of? Are they able to weigh up the risks versus benefits of said decision? And lastly, are they able to communicate their decisions regarding or their wishes regarding this specific decision? Capacity can fluctuate, as I said before. Um, and if the patient fails any one of the four domains that I've mentioned, they are deemed to not have capacity. Oh, sorry. For this one, it shouldn't be true or false. It should have been open ended as well. But we'll skip this question. And this one as well. Can you, oh, actually, okay, do you know what main types of sections are used in psychiatry? Ignore the things at the bottom. If you could put in the chat and editor can kind of kindly read to me the kind of main sections that people are aware of. If you're unsure, then we'll probably just move on to the presentation. But if you know the main types of sections that will be used in an acute ward, just write it down in the chat quickly, and maybe Aditya will kindly just read out what people have put.
We've got section 25.
Section 25, okay. Are there any others?
Section 2.
Yep.
Section 3.
Section 3, right? Yep. Does anyone know kind of the main section that a junior doctor would be able to use to detain a patient for on a ward.
Someone also said section 5.4 and
Yeah,
section 5.2
yeah, correct.
and
So
41.
and 41 as well. I think 41 might be a forensic section. So as you can see, there's a lot of different or differing sections for patients. The main ones that I myself have come across whilst working within the NHS on the psych ward would be section 2, which is the initial type of section 2, section 136, section 135, and section 3. Section 5.2 is often used by doctors as well, and section 5.4 is used by nurses. So section 2 allows us to detain a patient on the ward for up to 28 days. And once they come onto the ward, they have their section rights read out to them, and they're able to appeal the sectioning within 14 days through an appeals process known as a tribunal, where you yourself as the treating physicians will go into a court-like setting where the patient and their legal representative kind of argue against the grounds for their sectioning, and it's up to you as the treating team to kind of give your rationale for why the patient needs to be on the ward. Section 2 is usually for the purposes of diagnoses. So someone comes onto the ward and they're presenting in a specific manner, whether there's floridly psychotic features that are observed. It's your responsibility to kind of give the rationale for why it's within their best interest to remain on the ward in kind of a detained setting for diagnoses. Section 3, which can last up to 6 months, meaning patients can be on the ward for a 6 month period, is primarily focuses on treatment. Because once we have a diagnosis for a patient and we've initiated treatment that hasn't been optimized within the first 28 days of a section 2, we then progress onto a section 3, and the need for section 3 kind of revolves around treatments. You have to do a section 3 recommendation whereby you kind of convey what features have been observed on the ward, whether it be kind of auditory or visual hallucinations that aren't appropriately managed yet, self-harming behaviors, agitation, and also kind of you'd kind of convey what the patient's progress has been thus far, if any at all. Section 5.2 allows doctors to detain a patient for up to 72 hours. And then within that time, if a patient is unwilling to remain informal on the ward, said you would then have to fill out the paperwork for a mental health act assessment. So all these sections are under the mental health act assessment. So you would then kind of petition for a section 2 to have the patient detained on the ward. You have section 5.4s, which are done by nurses, and it allows the nurses to detain the patient for up to 4 hours. And then a section 135 and 136 are kind of like community-based sections where police will detain a patient in the community. Section 135 allows them to go into a patient's property and detain them there, and then bring them to hospital or a place of safety, i.e., the emergency department or a designated space of safety for their own good, whilst the Mental Health Act assessment is organised. So those are the main sections, and I think that is it. For the last one, what might a risk assessment kind of entail? So when you have a risky patient that's come onto the ward, you know that prior to coming on the ward, they kind of engage in poly substance misuse, they self harm, or they've even kind of come through the ED pathway with an overdose, why might we want to risk assess the patient? Self-neglect, if they present harm to self-harm, eating disorder, risk to others. Yep, all of the above is correct. Suicide risk, yep. So as soon as a patient comes onto your ward, as the clerking doctor or the treating team, the patient is assessed on a 24/7 basis, and every kind of interaction kind of warrants a risk assessment, especially when they first come onto the ward and they're not known to you. Even if they are known to you, you need to do a current and up-to-date risk assessments. So risk assessment comprises of risk of self to self, risk from self to others, and risk from others to self. So you're kind of gauging what are the risks that the patient poses to themselves. Do they have a history of overdose? Do they have a history of substance misuse, which leads to a worsening mental state, or even potentially withdrawal symptoms, which can impact their physical well-being? Do they have a risk of death by misadventure? Because some patients, for example, if you had a bipolar patient that was manic and felt undefeatable, that was just very like prone to impulsive behaviors, they could be at risk of death from misadventure. Or if the patient, for example, has a history of substance misuse, they once discharged, if a thorough risk assessment isn't done, they could kind of overdose on their medication because you've given them a month's supply of medication, and they're feeling depressed at the time, and they have this massive stock of meds at their disposal. Risk of self-neglect is one as well. Is the patient prone to self-neglecting with a worsening mental state? Risk from self to others, is the patient a very agitated patient that's prone to physical and verbal abuse and violence? Has the patient got children, and when in active psychosis, have they ever tried to harm the child or themselves? Has the patient ever brandished any bladed article? All these things are why a risk assessment needs to be done. And the most clear example to use is when a patient comes onto the ward and they're kind of the in you're experiencing the worst possible version of their presentation. Nursing staff have to manage them 24/7. So, what level of observation do they need to be on? Is the patient having active suicidal ideation with intent and plan? Are they prone to swallowing objects such as lithium batteries? Do they tie ligatures? So, if the patient comes onto the ward, you would do the risk assessment and see that they're prone to swallowing objects. So you try to remove any harmful objects from the room. Do they tie ligatures? In which case, you would have to remove their shoelaces or any kind of cords from their room. And yeah, and risk of non-compliance is another risk as well, which can lead to worsening mental state, and that's a risk from self to self as well. Okay, so that is everything as far as that introductory question. It seemed like you guys had a good kind of base as far as those kind of key niche elements of psychiatry concerned. So what will we be exploring in today's talk? The role of the junior doctor, which we've briefly explored. We're going to look at some psychotropic medications. You're by no means expected to know these medications or their kind of mechanism of actions, doses, or effects, but something that you can read upon privately if you are interested. So we will look at the main classes, the uses, and key side effects. And we're going to look at the agitated patient and rapid tranquilization, physical health in psychiatry, monitoring. We'll look at a few key psychiatric emergencies, and then we'll end things with one of the kind of main pathologies that you'll see in psychiatry on an acute ward, which is schizophrenia. And then we'll quickly explore a case that I've recently encountered as well before ending. So what's the role of a junior doctor on an acute inpatient ward? Some of the things that we mentioned, such as clerking, new admissions, performing a mental state exam, the daily ward round review and notes. I can't emphasize enough that as a junior within psychiatry, you'll be doing a lot of the kind of annotation and scribing, and you will be kind of present in all the ward round reviews with the consultant. Ward rounds are typically done once a week for a patient, unlike in the general side where it's daily. So you see maybe 5 patients a day in clinics, and they're seen at least once a week. At least once a week. You complete your physical health checks, your blood test, your ATE assessment, your ECG prior to initiating any antipsychotic medication, and you'd also prescribe. You'd explore legal and safeguarding, so understanding the Mental Health Act, completing the relevant sections, and explaining the patient's uh, section rights to them. You perform a capacity assessment. Um, Typically, when the patient comes onto the ward, the two things that you assess are capacity to admission and capacity surrounding treatment on the ward. Whilst under section, you are allowed to treat patients against their consent with medication, as long as it's deemed to be in the benefit of their mental states. It's more complicated when it comes to physical health, though. And then you document the risk. So communication, which is an important theme or responsibility. When working in an acute psychiatric ward, we typically work as an MDT, which is short for multidisciplinary team. Um, so we liaise with nurses, families, carers if the patient requires a package of care or additional support within the community. We frequently meet with social workers and care coordinators, and we work with the community mental health team as well. So, what other responsibilities do we have as a junior doctor? We have our learning and development, which need to be prioritized. Typically, within the NHS, you might have a weekly supervision meeting with the consultant to describe any difficult cases. Um, you may kind of explore your psychopharmacology knowledge, recognize and learn how to recognize and manage some emergencies, or even do case presentations and reflective practice. So, what are some of the psychotropic medications we could expect to be used on a psych ward? So, we have first and foremost the typical antipsychotics, such as haloperidol and chlorpromazine. These are first generation antipsychotics and they're extremely potent, which is good. So that means they're very effective in treating things like psychosis, mania, agitation, delirium. However, the downside of these medications are the side effects are significant when using them as well. So you can experience things such as extrapyramidal side effects, which we mentioned earlier. Um, you can experience tardive dyskinesia, which is the involuntary movements, and you can have prolonged QTC, which can, as we said earlier, lead to dangerous arrhythmia and sudden cardiac death if not properly monitored. And with the antipsychotic medications, when you're up titrating, which is increasing dose, or down titrating, which is decreasing the dose, it can have significant effects. So we tend to increase and decrease the medications very, very slowly. You have your second generation antipsychotic medications such as olanzapine, quetiapine, risperidone, aripiprazole, and last but not least, clozapine. So on the ward, you would start patients on typically an atypical because, again, they're effective, and another added benefit is that the patient does experience less kind of side effects. Some of the side effects can even be beneficial. For example, you have a patient who's got a diagnosis of anorexia nervosa. they're underweight and they're floridly psychotic, talking to themselves, laughing inappropriately, or they're responding to unseen stimuli. Um, you treat them with olanzapine because again, it can treat the psychotic symptoms and features, and it can the beneficial side effect would be the weight gain. It kind of encourages the patient to be more hungry and want to consume more food. So the benefit there would be weight gain. And another one would be, let's say, quetiapine, which is given at night. It has kind of like a sedative and calming effect. So if you're treating someone that was psychotic that struggles with sleep, you would give quetiapine because of the improved sleep. That's an added benefit as well. And one of the most important antipsychotic medications, which is a second gen, which is used, which is commonly used when the patient has treatment-resistant schizophrenia, is clozapine. So clozapine is a very potent and effective medication. It's often viewed as the last resort as far as antipsychotics are concerned. The only downsides are some of the side effects are quite severe as well, and it requires a lot of monitoring. The patient would have to have vitals twice daily. So they have pre-clozapine vitals and post-clozapine vitals. They need to have regular blood tests for a set period just to make sure that they don't experience agranulocytosis as well. And a lot of the time as well, patients that are on clozapine um, do experience tachycardia, so they might require a rate controller such as a beta blocker. So they may need like something like bisoprolol, maybe a low dose, 2.5 milligrams, just to manage the tachycardia. What other medications would we use in an acute ward? We typically would use mood stabilizers and antidepressants. So most common mood stabilizers utilized would be lithium, which is a gold standard, and in terms of treating bipolar patients. It does require monitoring, however, and the reason it requires monitoring is that it can impact the renal system and the thyroid gland as well. You have valproate as well, which is used to treat mania and epilepsy. The only issue is that it's teratogenic, so it can affect women of a childbearing age. So it's typically avoided. You have lamotrigine, which is another standard mood stabilizer used in bipolar depression, and you have carbamazepine as well. You have antidepressants. You have your SSRIs and your SNRIs, such as sertraline, fluoxetine. These are typical first line antidepressant medications. They may be started by the GP in the community, but they will be up titrated and optimized on an acute ward. So your SNRIs are venlafaxine, which can increase blood pressure at high doses. Um, and for example, with your sertraline as well, you can have gastrointestinal disturbance, sexual dysfunction as well, and it does increase the risk of a psychiatric emergency, which is called serotonin syndrome. You have your MAO inhibitors, which are used as a last resort, and metazapine, which has a sedative effect as well. That would be an antidepressant that you would use in the night purely because of the sedative effect and the improved sleep. You have your anxiolytics. So your anxiolytics typically comprise of your benzodiazepines. So on an acute ward, typically we would use lorazepam. We would use it oral if the patient is kind of willing to take medication and they're quite anxious or agitated. Um, this has kind of like a very calming effect. The only downside to the benzodiazepines are you run the risk of dependence because they're quite addictive. You have your Z drugs such as Zopiclone and Zolpidem as well, which again have a similar dependence risk to the benzodiazepines and are kind of like used to treat insomnia. So those are the medications you would give if a patient was suffering from sleep disturbance. Um, your Z drugs are typically used in your older age patients, so patients that are over the age of 65. You would, and the reason you would use them in those patients are because with increased sedation, you run the risk of increased falls as well. And a lot of the patients, when they reach that kind of age bracket, they may be on various medications that increase their risk of bleeding, and they may be confused already. And if you combine confusion and kind of like poor mobility with sedation, then you run the risk of falling down. And one of the medications kind of used as an adjunct in treating either agitation and insomnia is promethazine, which is an antihistamine. Promethazine would be used in your general adult population as opposed to your older adult because of some of the effects that I mentioned earlier. It increases the risk of kind of sedation, and if you have someone who's cognitively impaired, increasingly confused, and has poor mobility, they may be more prone to a fall. And you don't want them to get like a subarachnoid hemorrhage or their brain bleed. Um, so you definitely opt for your Z drugs um, for the older age population. And we also have buspirone, which is an anxiolytic, so it's an anti-anxiety medication. Um, some GPs will start patients on propranolol, which is used as an anxiolytic within the community. So, what are some of the key prescribing gems we should kind of consider? So, as previously mentioned, we want to try and avoid we want to monitor kind of patients that are on clozapine because of the risk of agranulocytosis. We want to avoid polypharmacy where possible. So this is kind of like over prescribing different medications to try and combat patient symptoms. You want to start patients on one medication at a time and properly observe the effects of the medication before considering adding adjuncts. You want to, for patients that are on lithium, you want to avoid lithium toxicity, so they require a lithium level every so often just to kind of avoid toxicity. And signs of toxicity include tremor, ataxia, confusion. We want to monitor patients' weight because when they're on some of the antipsychotic medications, it can lead to unwanted weight gain and metabolic syndrome. And we always want to check a patient's QTC before initiating antipsychotics, especially if they're antipsychotic naive, because it can lead to arrhythmia and, as we said before, sudden cardiac death. So, how do we manage an agitated patient? Imagine you've been kind of you've had a forensic encounter with the police. They've grabbed you from your house. You don't understand why you've been forced to leave your home, and you've been brought onto a ward with people you don't know who are saying strange things and doing even stranger things, and you're just quite upset and angry, and you're kind of struggling to process your emotions at the time. How do we manage someone who's quite angry? So we start off with verbal de-escalation. We never want to opt for medication first if the patient can kind of be spoken to, verbally reassured. And the reason the way in which we practice verbal de-escalation is by taking the patient to a calm environment. On some psychiatric wards, we have a de-escalation room where we take patients. It's kind of like a bare room where there's a lack of stimulation from other patients or the environment, because on a psych ward it's not kind of just quiet and well organized. There's a lot of shouting. There's odd things that are going on where patients may be laughing inappropriately, screaming, staring blankly and intently. So yeah, we want to reduce the stimulation that the patient's experiencing. You want to opt for a non-threatening stance. You want to kind of actively listen and reassure the patient. Try to identify their needs, because there might be some kind of environmental trigger or kind of some needs that may not be met by you as a team that is triggering the patient. And if you can't verbally de-escalate, then you would opt for offering oral medication. As I said previously, we do like to choose go for a benzodiazepine. when this fails. So we'd opt for lorazepam 1 to 2 milligrams if the patient is a general adult, so under the age of 65. Um, if they were an older adult, you would kind of half the dose. So you'd go for zero point 0.5 milligrams to 1 milligrams based on the degree of agitation. Um, you can offer some antipsychotics to calm the patient down if they're not antipsychotic naive and if you've had an ECG. But typically, your kind of gold standard medications that you'd want to use would be lorazepam, oral or IM if the patient is refusing the oral medication, and promethazine. So you also have your intramuscular rapid tranquilization. This is step 3. Now, this is if the patient is extremely violent, agitated, and kind of now has become physically abusive. It would warrant kind of a sounding of the alarm. On a psych ward, as an SHO or any staff member on a psych ward has a pendant alarm that they can press in times of distress. So if a patient, for example, has cornered you as a staff member and you're being singled out and they're being verbally abusive, they're invading your personal space and have even resulted in blows, i.e., slapping, punching, biting, and even spitting, which is a common occurrence on our wards. You'd press the alarm, the team would come, maybe they'd prepare some kind of IM medication if the patient couldn't be spoken to or if they were refusing to take their oral medication. And that would be administered with the hope of calming the patient. And you do that in as safe a way as possible. Staff on psych wards, mainly the nursing staff, are trained in restraining. So they do that as safely as possible. And then you have your post rapid tranquilization monitoring. So you assess the patient's respiratory rates as benzodiazepines, for example, or respiratory depressants. You assess their oxygen saturation levels, their heart rates, blood pressure, the levels of consciousness, and you have resuscitation equipment available. And what you must do is document the encounter and rationalize why you had to resort to IM, because again, this is a very kind of traumatic experience for a patient. Imagine that you've been kind of held down, pinned, and injected with something that you didn't kind of agree to take. Yeah, so it's very restrictive. So we have to have clear rationale and good reason for opting for IM medication. What are kind of the key cautions and contraindications within psychiatry? You want to avoid particular combinations such as intramuscular olanzapine and intramuscular benzodiazepine because there's a risk of fatal respiratory depression. You want to avoid some of the first generation antipsychotic medications or be quite conscious of them, of giving them if the patient has already has a prolonged QTC or a pre-existing electrolyte imbalance. And you want to kind of be cautious of giving promethazine, the antihistamine, if the patient has some kind of respiratory compromise present at the time of administration. So when patients are detained under a Section 2 and 3, in order to treat them under the Mental Health Act, like we discussed earlier, consent isn't required for this. So whilst under the Mental Health Act, you are you're not only encouraged, you're obligated to treat the patients because they're extremely unwell. It's affecting their quality of life, and the patient, by and large, could pose a risk to both themselves and others within the community. You want to assess patients' capacity and put them under a DOLS as well, which is a deprivation of liberty safeguards, typically done in old age wards. You want to treat them under an emergency section, such as Section 62, if required. And you always want to document your clinical rationale and capacity assessments and opt for the least restrictive option. Some patients as well, this is just by the way, can come onto the ward as involuntary patients. These patients usually have capacity and have insight requiring their own surrounding their illness, so they can be admitted onto the ward. However, if, for example, they begin to deteriorate and they seemingly lack capacity or lose insight surrounding their illness and treatments, then you need to consider maybe opting for a section 5.2 and then triggering a mental health act assessment so that they can be kept for at least 28 days. Some considerations are surrounding elderly population. Typically, we would halve the doses because they're at risk of delirium and there are high falls risk as well. If you're dealing with a pregnant patient, as a junior doctor, you want to seek advice from your seniors because a lot of the medications can be teratogenic. Um, Again, when it comes to prescribing antipsychotics, as a junior, so that would be CT3 and under, you wouldn't be expected. So as a core trainee and under, you wouldn't be expected to necessarily make medication decisions. This would be the responsibility of the registrar and the consultant as far as antipsychotics are concerned. So that pressure isn't necessarily on you. You're kind of more concerned with effecting the recommended changes and knowing how to kind of calm an agitated patient with your benzos and whatnot if required. And then obviously you would be expected to kind of prescribe and know how to manage physical health complaints such as like hypertension, your heart failure, maybe acute kidney injury or diabetes, things like that. You'd be expected to manage. And when kind of treating unwell patients, you always want to try to rule out organic cause. For example, within the older age population, they're more prone to urinary tract infections, head injuries, and kind of metabolic dysfunction. So, is that why the patient's presenting as delirious or agitated? So, you want to rule out those causes first before kind of opting for increasing the dose of their treatment. And where after kind of rapid tranquilization, key considerations are reassessing the patient's mental state within an hour, reviewing their regular medication. Was the rapid tranquilization avoidable or was it necessary? And debriefing the patient when they've maybe calmed down as to why you had to inject them. Because as you can imagine, you're not going to really trust someone who's kind of restrained you and then injected you. So you want to do therapeutic rupture repair by debriefing with the patient as to why this happened and how maybe they can avoid this in the future. You want to monitor the vital signs as per many NHS trust protocols, and document the time the medication was administered, the route and the dose, and then the response to the medication as well. Just so that in the future we can know whether there was a positive therapeutic effect or whether the patient might require an increase in medication. So, physical health and psychiatry. As we discussed previously, what are some of the physical health concerns or what monitoring would be you expected to do on a psych ward? So when doing admission bloods, the minimum you'd need is a full blood count, your renal function assessment, your liver function test, thyroid function test, glucose test, HbA1c. You'd assess the patient's lipid profile, CRP, and calcium and magnesium, for example, if they required refeeding bloods. You'd want to assess drug levels if required, do blood cultures if the patient is febrile, and perform a urine dip. Urine dip is one of the urine dip and pregnancy tests are typically done for patients, especially on the female ward where the pregnancy test is concerned. You would do a urine dip if the patient is under 65, but you wouldn't do a urine dip for a patient that was over the age of 65 because typically on a urine dip you may get trace levels of protein, nitrates, and leukocytes. So you need a more sensitive test. So you do an MSU for that. You have your cardiac monitoring. You do your ECG just to assess QTC prolongation. So if the QTC is under 440 milliseconds and on the ECG in men, it's normal. If it's under 460 milliseconds in women, it's normal. You want to get a base level of for their weights. Patients are weighed weekly on the ward. Patients have their blood pressure taken daily on the ward as part of vital signs, and you want to kind of gauge their substance use history and like the levels of physical activity. Again, you can see some of the monitoring you do for somebody that may have metabolic syndrome, especially if they're on particular medications such as olanzapine, which kind of promotes weight gain. Quetiapine and clozapine as well seem to have a similar effect. And you have your other physical health concerns that you'd have to monitor, i.e., dental kind of monitoring. You're not expected to treat these things, but you can do an emergency dentist appointment for the patient. You can refer to podiatry if, for example, they have very bad feet or nails and they require a review and assessment. You screen for your diabetes, dyslipidemia, and hypertension. You'd want to try promote smoking cessation as well. The trust that I'm a part of, we kind of advocate for nicotine replacement therapy, as and where patients that want to change their lifestyle are concerned. You want to monitor for constipation, as it's a very common side effect of antipsychotic use, especially with regard to clozapine. They're put on a kind of bowel chart when initiated on clozapine because they can develop um, clozapine related ileus, which can be life threatening. And then you have your monitoring for key medications such as lithium and clozapine, which we discussed earlier. What are some of the psychiatric emergencies we may encounter? You have something called neuroleptic malignant syndrome, which is a rare but life threatening antipsychotic emergency where a tetrad is observed. The tetrad consists of hypothermia, increased rigidity, which can be described as lead pipe rigidity. You have altered mental status or levels of consciousness, which vary from confusion to the patient being comatose. You have autonomic instability, which includes the patient becoming tachycardic, labile in their mood, um, blood pressure, patient sweating profusely, or seemingly being in respiratory distress and having an increased respiratory rate. And the onset of this life threatening emergency varies from hours to days after starting or increasing antipsychotic medication. Investigations you would do to rule out this life threatening condition would be assessment of creatine kinase, um, assessment of white blood cells, liver function tests, creatinine, your urine myoglobin, and possibly an ABG to rule out metabolic acidosis. And how do we manage this condition? So, number one, you would stop the offending agent immediately. So, whatever antipsychotic the patient was initiated on or increased, or sometimes even decreased, if that's the trigger for the condition, then you either try to gradually down titrate the medication or you just halt the medication use immediately. You transfer the patient to a medical facility that's more equipped to deal with the patient because in psychiatry, unlike the general side, you are limited in the forms of treatment you can do. We can't do cannulation on the ward. We also can't. So if you can't do cannulation, that means you can't give IV fluids on the ward. And another limitation on the ward is we can't catheterize patients or do speculums as well. Um, yeah, and that's bad in this condition because if someone's got query NMS, you need to give IV fluids just to prevent them from having acute kidney injury. You'd opt to cool the patients, and means of doing that would be with ice packs, which are a physical means of cooling, or antipyretics. Um, if the patient is experiencing the lead pipe rigidity, you might want to opt for a muscle relaxant as well. And if they're agitated, you could use lorazepam, which is a benzo, and that would calm them down. And the benefit of that is that it does have some muscle relaxant properties as well. And you continue to monitor the key markers such as creatine kinase, their renal function, and their urine output as well. But the main thing that you would be concerned with is just transferring them off the ward. because we don't always have it's an emergency and we don't have the tools that we need to manage this patient. Another key emergency is serotonin syndrome, which is excess serotonergic activity in the nervous system, often from various drug combinations. The most dangerous combinations are your SSRIs and your MAO inhibitors. So as you can see on the left-hand side, there's just various combinations that can lead to this. There's a specific criteria that we use called Hunter criteria, where we monitor for neuromuscular abnormalities such as clonus. We monitor for hyperreflexia, tremor. We assess autonomic instability, and like we mentioned with NMS, so that's your tachycardia, your diaphoresis, your hypothermia, and potentially diarrhea as well. And we assess altered mental status such as agitation, confusion, restlessness, and anxiety. The most distinguishing features from serotonin syndrome are clonus and hyperreflexia, especially of the lower limbs. And you've seen from both psychiatric emergencies, there are some overlap in symptoms. So what we want to do is compare things such as onsets. With serotonin syndrome, the onset is quite rapid, so it happens within hours. Whereas with NMS, the onset is quite gradual, so it can occur from hours to days. You want to assess rigidity. So in NMS, you'd expect the patient to have lead pipe rigidity, whereas in serotonin syndrome, the patient would experience clonus and hyperreflexia. Creatine kinase can be elevated in both. And you want to assess maybe the patient's bowel sounds as well. So we have reduced bowel sounds. So they would be hypoactive in a patient with NMS, and it would be hyperactive in a patient with serotonin syndrome. And how do we manage this condition? Again, in psychiatry, a key takeaway is always to potentially stop the offending agents and then to treat the other symptoms such as agitation, anxiety, tachycardia, and pyrexia as well. And you want to offer supportive care. And again, because it's a psychiatric emergency and we may not be well equipped to manage it on the ward, we can send the patient to the intensive care unit. Other psychiatric emergencies consist of overdoses, dystonia, lithium toxicity, which we've explored before as well. So if you have a patient who's a chronic self-harmer and overdoses quite often, you always want to do your ATE assessment first, assess their airway, is it patent, are they verbally responding to you, assess their breathing, is the chest clear, do you have bilateral, do you have equal bilateral air expansion, are there any pathological sounds? Do they have bronchial breathing, which is pathologic, or do they have vesicular breath sounds, which is normal breath sounds? You assess the circulation, so the capillary refill time. You assess their pulse. You listen to their heart sounds from all the valves, and then you assess their GCS in disability. Are they alert? Are they conscious? And then exposure, which would be maybe any signs of self-harm, maybe cutting, ligatures. And then you'd call the emergency team if required. And then you've got potential offending agents such as paracetamol with their and opioids with their corresponding antidotes, which is N-acetylcysteine for paracetamol and naloxone for an opioid overdose. And sometimes patients will overdose on benzos. I think we're less worried about benzo overdose on the ward as compared with the others, but it can happen. And if a patient on the ward is experiencing kind of dystonia, you treat it with procyclidine, which should help with that. So we move on to one of the key pathologies observed in psychiatry, which is schizophrenia. We'll quickly go through some of the elements associated with schizophrenia. So it's a multifactorial neurodevelopmental disorder. It has a heritability of 80%, and 1% of the general populace are at risk of developing schizophrenia. There's a strong genetic correlation between mental health illness and you developing it. Things that kind of increase your risk of developing a mental health illness are increased travel and stresses as well. So, what causes schizophrenia? What's the etiology? So, typically, there's a few hypotheses that we'll explore. There's the dopamine hypothesis, whereby excess dopamine receptor activity in the mesolimbic pathway results in positive symptoms of schizophrenia. You have the hyperdopaminergia in the prefrontal cortex, which can cause negative symptoms or cognitive symptoms in schizophrenic patients. You have enlarged lateral ventricles, which cause reduced hippocampal volume as well. And that's another kind of theory surrounding schizophrenia. So, what are the environmental risks? Having an urban upbringing, migration, and social adversity. So, your migration, your stress factors, your substance misuse. There's a strong correlation between developing schizophrenia and substance misuse, especially with drugs such as cannabis or skunk. Being of advanced age, experiencing obstetric complications such as hypoxia, childhood trauma, and abuse. So these are your patients that have complex PTSD, and then the winter spring birth viral hypothesis. What are some of the symptoms we'd expect from a schizophrenic patient? You have your auditory and visual hallucinations, your olfactory hallucinations, your somatic hallucinations as well. The patient may experience persecutory delusions. There may be referential, there may be grandiose delusions as well. Like, I've worked for the Queen, I'm a cardiologist. I performed open heart surgery last week and I can fly. God has chosen me to kind of lead his people. These type of things, very, very grandiose. The patient, as far as their thoughts, may experience thought insertion, whereby they feel thoughts are being implanted into their mind, thought withdrawal, where they maybe become catatonic, or thought broadcasting, whereby they feel like you can read their mind, which makes them very paranoid and agitated and suspicious. We've had patients on the ward become so paranoid that they don't shower because they think the water's been tampered with and is poisoned. They won't drink or eat because they think the food has been tampered with. And is also poisonous as well. And some patients maybe experience paranoia to the degree that they think maybe a particular race of a particular race is kind of targeting them. People are targeting them. They've been hacked. They've been a victim of identity theft or financial fraud. So all of these things. Patient might have disorganized, incoherent speech and behavior. They may have formal thought disorder, an experience of flight of ideas or a loosening of associations, which is why we do mental state examinations whenever we review a patient, so that we can have ongoing assessments of the progress and kind of how the medications impacting these symptoms. You have negative symptoms. So you have the A's, such as alogia, which is a poverty of speech, avolition, which is lack of motivation, which is can be common in schizophrenia and your depressed patients. You can have anhedonia, which is also observed in patients with clinical depression, whereby the patient doesn't experience pleasure from previously enjoyed activities, maybe such as gym, going to the movies, studying, and then you assess the also affect can be affected. So patients can have a flat affect or a blunted affect, or they can socially withdraw as well. These type of patients are less responsive to antipsychotic medications. Um, and then you have your cognitive symptoms where memory is impacted or impaired, and they have reduced processing speeds and executive function. So they may experience psychomotor retardation. And kind of a diagnostic criteria tool that is used is ICD-11 or ICD-10, depending on where you are. And it's a gold standard for diagnosing a patient with schizophrenia. So you have two or more core symptoms for over a month, you may be diagnosed with schizophrenia. If there's significant functional decline, you may be diagnosed as well. You want to exclude organic substance or mood disorders. And you can use Schneider's first rank symptoms, such as passivity, thought insertion, running commentary, and somatic hallucinations, kind of as a means of giving you an inkling to whether a patient might be schizophrenic. So, how do we manage a patient with schizophrenia? We've explored some of the pharmacological treatments, such as your antipsychotic medications, your first generation and second generation. Another alternative is to start the patient on second generation antipsychotic medication orally and build up their tolerance to a degree whereby you can then give the long acting injectable form. For example, when you have the oral antipsychotic medication, such as risperidone, you would give it orally, and then you would then give them a loading dose of the injectable form, which would be paliperidone. They're given then a subsequent dose on day 8 after receiving the loading dose, and then they're given their maintenance dose subsequently, which can be once a week, fortnightly, or monthly. But then they have to attend the depot clinic on discharge to continue receiving the medication. In terms of management, you have your psychological therapy, such as cognitive behavioral therapy, psychoeducation, which we've mentioned before, social skills training, which are typically done by the occupational therapists, psychoeducation of the family as well. And whilst on the ward, they may engage in therapy such as arts, mindfulness as well. And kind of social and systemic forms of treatments are supporting the patient's employments once they've overcome the crisis period. You don't want to send them straight back to work or encourage intense education or employment if that's going to be a stressor and trigger relapse. You want to make sure that their housing is sorted, as this can be a potential trigger for relapse as well. And you want to refer them to the appropriate team, i.e., the early intervention team as well, and the community mental health team. So we're going to go through a case quickly that I recently encountered. So there was a 22-year-old patient who was urgently referred by his GP. On assessment, he was guarded and intermittently distracted. He described hearing 2 voices, one male, one female, that comment on his reactions and occasionally issue commands to him. So he's having command hallucinations or command impulses or voices. And he believes he's under surveillance by a shadowy organization linked to his university. I'm sure a lot of us can relate to that. He denied experiencing suicidal ideation, but he kind of proposed that the organization wants him dead. He did disclose that he does use cannabis occasionally, but denied any other substance misuse, i.e., your opioids, your crack cocaine, your heroin. He has no previous psychiatric history, and no family history of psychosis was found as well. And his functionality was good prior to this. He was a straight A student. As far as the history of his presenting complaint was concerned, over the past 6 weeks, his mother had noticed him become increasingly withdrawn. He started neglecting his studies, and he spent long hours alone in his room. So he started to self-isolate as well, which is a sign of deteriorating mental health. He'd been sleeping very little, eating erratically, and he communicated in a jumbled up manner. Also, he was incoherent in his speech. He accused both his mother and 2 neighbors of planting thoughts in his head via a hidden device in the ceiling. So we have thought insertion here, whereby he thinks that his actions and what he's thinking is a result of a device that's been implanted within the home. And as a result of this profound paranoia. He ended up barricading himself in the room for 24 hours. So, as far as his medical history and psychiatric history is concerned, he had no previous episodes to date. So, this is his first psychotic episode. He has a medical history of asthma, which was diagnosed in 2017, given his age, which makes sense. And he had no previous psychiatric history. So, on mental state examination, we assess the key domains such as appearance, behavior, speech, mood, thoughts, perception, cognition, and his degree of insights. So he presented as unkempt during the review. He presented with poor eye contact, psychomotor agitation. His speech was tangential, so he's going off on tangents. He was he was of normal moods, which he reported, but incongruent affects, meaning that his affect wasn't in keeping with his reported mood. As far as his thought content was concerned, he was experiencing persecutory and referential delusions. He was passive. He was experiencing thought insertion, and he had perceptual abnormalities whereby that third-party people were kind of altering his perception of things. He experienced auditory hallucinations with running commentary and command elements. But as far as his cognition was concerned, he was alert and oriented in time, place, and person, but he lacked insights. So, what was some of the management strategies discussed for said patients? Due to it being the first episode of psychosis, these types of patients are more sensitive to antipsychotic medications because they're antipsychotic naive. So we want to start on an atypical antipsychotic, and we start at the lowest dose possible. Potential medications that we would have considered for this gentleman would have been potentially aripiprazole or risperidone, and then you'd kind of start on the lowest dose possible, give it maybe 3 to 5 days, and see if the voices and the delusions kind of started to quiet down. And if they didn't, then you would up titrate the medication appropriately and slowly. And this is all pending the admission investigation, so your ECG, physical health examination, and whatnot. So, what's some of the key takeaways we can learn from this case? It's always good to exclude organic causes, especially autoimmune encephalitis in patients that are young and are experiencing the first episode of psychosis. We always want to refer them to the early intervention team on discharge and as early as possible, as this practice is associated with better outcomes. And another takeaway is that the patient was on cannabis, and it's the most important modifiable risk factor for psychosis and potential relapse. So you want to address the patient's kind of substance misuse and maybe refer them to the relevant community team, maybe the addictions team, just to support the patient with kicking their habits. Okay, that brings the presentation to a close. Apologies for taking up so much of your time, but I hope it was informative and kind of has given you a greater insight into psychiatry. Does anyone have any quick questions to ask? If it's within my kind of remit to answer, I will do my best to answer. Or if you also have any questions on transitioning back to the UK, if you're an IMG or what working in the NHS is like, it can be non-psychiatrically related as well. I'll try to answer or give my take on things.
They asked, did you go to psych after med school or did you do FY1?
Post med school, if you're an IMG, I can empathize. I studied in the Medical University of Sofia. On coming back to the UK or transitioning back because I'm a UK citizen, I did clinical attachments in general surgery and renal medicine. I locumed in general surgery, and then I proceeded to locum in psychiatry. And it's that kind of locum experience within psychiatry that piqued my interest in the discipline of mental health as a whole. Prior to that, I had an interest in radiology. To be fair, at the time, so yeah, I hope I answered the question. So yeah, post finishing from uni, I kind of transitioned straight into the NHS as an SHO in psychiatry. It's the bulk of my medical experience or career experience thus far. I have dabbled in renal medicine and general surgery though as well.
Guys, any other questions?
Can be non psychiatry related as well. Pardon?
Did you have to sit PLAB exams?
As far as the PLAB exam is concerned, I did not have to do that because because I'm a UK citizen. So when I was transitioning back, all I had to do was the language test to showcase that I'm proficient in the English language, and then I registered with the GMC, and then I was good to go. As far as the process is concerned, I don't think it's changed as such for UK citizens, apart from the introduction of the UK MLA. To be fair, that's the only major change since I graduated. My graduating class was in 2024, so we missed the UK MLA. I'm not sure whether the subsequent year groups have been mandated to do it and how that's going though.
As you mentioned, you have done quite two non-technicals. What psych post are you on at the moment? That's
At the
all.
minute, I'm working in an acute female general adult ward. So typically, the main divisions of psychiatry are the memory clinic. You have addiction service. You have psychiatry liaison, which is the psych doctors that work in between the inpatient wards and the physical health wards. So they kind of manage the flow of patients from, let's say, cardio, resp, renal medicine onto the psych ward. Patients that aren't medically optimized aren't really supposed to be on a psychiatric ward because their physical health issues can impact their psychiatric presentations as well, or exacerbate them, or even mask them as well. So they need to be medically optimized prior to transfer. And psych liaison are kind of the subspecialty within psychiatry that are responsible for that. So they give both advice to medics and surgeons on patients who are, let's say, medical patients or surgical patients with overlapping psychiatric pathologies. And they also kind of streamline the admission process for said patients from these wards if they require a psychiatric admission as well. And then you'll have your old age psychiatry as well, which is for your over 65s. A key criteria for them is being over 65 and having issues with their frailty. So you do a frailty assessment before accepting. And then you have your community mental health team as well. So those are the main ones. But I've worked in old age and I've worked in general adults. I'm trying to get a post in addictions if possible, or some form of community mental health, just for my own learning.
Yeah, actually, they wanted to know for trust doctor or CT1.
They want to know what, sorry?
Are you working as a trust doctor or CT1 post?
At the minute, I'm working as a trust grade doctor, so I'm not in a formal training program. I'm not sure whether many of you know, but recently there's been a legislative change within um, the within the UK, whereby you have a priority group, non-priority group within the UK when doing the MSRA to become a psychiatrist or do obstetrics and gynecology, core surgical training or GP training as well. So I don't know. It's been very competitive thus far. So I'm exploring alternative pathways, and I'm working as a trust grade doctor at the moment, or your locally assigned doctor. They call it trust grade, LAS doctor, clinical fellow. It's just various terms for the same thing. It just means you're employed by the trust.
Question: how do you approach capacity assessment in someone whose presentation is fluctuating during an acute psychotic episode?
You capture the patient's capacity there and then, because capacity inherently can fluctuate, and capacity also does depend on the decision that is being queried. So, for example, if you have someone that's functioning well, by and large, 70 to 80% of the time on the ward, they seem calm in their mood and mental state. You don't observe any psychotic features or depressive features or negative symptoms if they have a history of schizophrenia. Um, you just assess the capacity there and then based on the decision being made. It could even be discharge destination, where someone is sound in mood and mental state but has a history of polysubstance misuse, and their home is, let's say, for lack of a better term, a crack den, and they want to go back to said home. Is that a capacitous decision? Do you don't understand the decision they're making? Can they retain the content as far as the risks that are concerned in terms of them relapsing their mood and mental state? Can the rest weigh up the risk and benefits, and then can they communicate the decision? Everyone's entitled to make a bad decision. We're not God, so we can't control people's decisions. The main thing with capacity assessments surrounding decisions are: does the person meet the criteria for all four domains? Can you understand? Can you retain? Can you weigh up the risk versus the benefit? And then can you communicate the decision? If the decision isn't kind of what we'd advocate for the patient, but they're capacitous, i.e., they're diabetic and they want to take their anti-diabetic medication, they're refusing to take their insulin, or not tracking their BMs weekly and submitting it to district nurses, you would still, if the patient is capacitous, that they're within their right to do that. Otherwise, it just becomes quite restrictive in terms of our practice. And where psychiatry is concerned, it's already a restrictive kind of practice that we engage in. So we try to minimize the restrictions as much as possible.
Any other questions? Okay, I think no more questions, doctor. So, thank you, doctor. Firstly, it is a amazing lecture, very informative. And thank you all for being here. And I hope you found this session informative, engaging, and inspiring. And looking forward to seeing you for further sessions. And guys, you can just fill the feedback form so that you receive the certificates. And yes, you can leave right now. Thank you.
Thank you.